Good morning, ladies and gentlemen. The topic of today's lecture is cutaneous B-cell lymphoma. Although this is not a very common disease to see, but I am sure that it is very difficult to understand from the textbook. So I have tried my level best to make this topic easier and understandable for you all. Before I discuss the different histopathological patterns of cutaneous and non-cutaneous B-cell lymphomas, I would like you to have a little revision on the histology of lymphoid follicles within the lymph nodes. So in the lymph nodes, there are two kinds of follicles, the primary follicles and the secondary follicles. Primary follicles are those follicles that are not exposed to the antigenic stimuli, and the secondary follicles are those follicles that are exposed to the antigenic stimuli. As a result of that, those secondary follicles, they are associated with germinal centers. So these are the follicles which are associated with the germinal center. So the germinal center itself comprises of a mantle zone, then a light zone and a dark zone. So the germinal centers in a follicle makes it a secondary follicle, and it also shows that these follicles are exposed to the antigenic stimuli. That is, the antigen presenting cells have presented the antigens within these follicles. This is another diagram of a lymph node with efferent and efferent lymphatic channels and two types of follicles, the primary follicles and the secondary follicles. Primary follicles does not have the germinal center, and secondary follicles have the germinal centers. The primary follicles comprises mostly of small dormant lymphocytes, while the secondary follicles, which is influenced by the amount of antigen exposed, has heterogeneous collection of large B lymphocytes that have been activated by the inciting antigens. So the primary follicles absorb less histological stain than the secondary follicle. This is likely due to fewer cells in primary follicles when compared to the secondary follicles. These are the primary follicles. You can see a monomorphous population of lymphocytes with no germinal center. Now these are the secondary follicles. You can see the germinal centers in the middle of these follicles. These are the germinal centers. So high power view of the germinal centers. This is a secondary follicles. Then this is a mantle. Germinal center is present in the center, which is a little lighter as compared to the peripheral cells, if we see at the scanning microscope, at the scanner. So the germinal center has an outer layer which is called as the mantle zone, and the inner layer which is the germinal zone. And the inner zone has dark areas and the light areas. Germinal center is subdivided into dark, light, and mantle zone. In the periphery of mantle zone has quiescent B cells that are characterized by intense basophilic staining. That is intense basophilic staining of the nuclei, less cytoplasm, and large heterochromatic nucleus. The other cells in the mantle zone are the antigen presenting cells or the follicular dendritic cells. The light zone of the germinal center, these are the light zone of the germinal center, comprises of centrocytes that interact with the follicular dendritic cells or the antigen presenting cells, which express antigens on their surface. So those centrocytes who are not involved in the antigen presentation, they ultimately die and result in apoptosis, and these are eaten up by the macrophages which are present in the light zone. These macrophages that have eaten up the apoptotic lymphocytes are called as the tingible body macrophages. So the dark zone of the germinal center comprises of centroblasts, which are highly mitotic and produce the muted antibodies. And these centroblasts also produce the centrocytes, which comprises of the lighter zone. This is a germinal center. This is a secondary follicle, and in secondary follicle center is a germinal center. Germinal center comprises of lymphoblasts, it comprises of macrophages, it comprises of antigen presenting cells, as well as the plasma cells. This slide shows the tingible body macrophages. These are the macrophages that have eaten up the apoptotic lymphocytes. This is a very important slide, and this slide is an algorithm of use of immunohistochemistry in the diagnosis of cutaneous B-cell lymphoma. The first and foremost stain to differentiate between a T-cell and B-cell lymphoma is CD20. So CD20 stains the B cells, while CD3 stains the T cells. So if we see a lymphocytic infiltrate in the skin lesion, then we order CD3 and CD20. And if the cells are primarily CD20, then it is a primary or secondary B-cell lymphoma, and we proceed accordingly. So the next stain which we will order in such cases is CD5. There are two types of cutaneous B-cell lymphomas: the primary cutaneous B-cell lymphomas and secondary cutaneous B-cell lymphomas. The primary cutaneous B-cell lymphomas are both CD5 negative. They are CD20 positive, but CD5 negative. These lymphomas are characterized by their first presentation on the skin. That is why they are called as the primary cutaneous B-cell lymphomas. And these lymphomas are follicular cell lymphomas and marginal zone lymphomas. The other type of B-cell lymphomas are secondary cutaneous B-cell lymphomas. These secondary cutaneous B-cell lymphomas are CD5 positive. And these lymphomas include small lymphocytic lymphoma and mantle cell lymphoma. So these lymphomas, they involve skin as a secondary involvement. So primarily these are restricted to the lymph nodes, but skin is involved as a secondary phenomena. And in addition to skin, other sites are also involved in such lymphomas. And these are relatively more aggressive as compared to the primary cutaneous B-cell lymphomas. Once a tumor is CD20 positive and CD5 negative, then we know that it is either follicular center cell lymphoma or marginal zone lymphoma. So then we go for CD10 and BCL6, which is positive in follicular cell lymphomas, and CD43 that is positive in marginal zone lymphoma. And if the cells are CD20 positive and CD5 positive, then we order CD23 and cyclin D1. So CD23 is positive in small lymphocytic lymphomas, and cyclin D1 is positive in mantle cell lymphomas. So this is how we come to the final diagnosis of B-cell lymphomas. So first we are going to discuss the primary cutaneous B-cell lymphomas. These are the lymphomas that involve skin as the primary organ, and they comprises of 1/4 of all primary cutaneous lymphomas. Most primary cutaneous B-cell lymphomas are indolent, and they have excellent prognosis, little tendency to nodal spread, and rarely require systemic therapy for treatment. And usually the local therapy is sufficient to treat the primary cutaneous B-cell lymphomas. Among the primary cutaneous B-cell lymphoma, the first lymphoma which we are going to discuss is the marginal zone lymphoma, which is also called as immunocytoma. It is an indolent cutaneous B-cell lymphoma that is derived from post-germinal center cells. That is, the origin is from the germinal center cells. It is characterized by proliferation of small lymphocytes, marginal zone B cells, and lymphoplasmatoid cells. Primary cutaneous marginal zone lymphoma is considered to be a part of a spectrum of extranodal marginal zone B-cell lymphomas that are often involve the mucosal sites, and such tumors are called as the malt lymphomas. Malt lymphomas. So these all are the malt lymphomas and primary cutaneous marginal zone lymphomas are all involving the skin and other cutaneous sites primarily. 10% of primary cutaneous B-cell lymphomas comprises of less than 10% of primary cutaneous B-cell lymphomas, the marginal zone, and present as solitary or clustered urticarial reddish-brown papule or nodules on trunk or limb. So as far as the clinical appearance is concerned, this appearance does not relate or characterize, is characteristic of this pathology. So it could be any pathology. And only on histology, this diagnosis comes up. The estimated 5-year survival is very good, that is 98 to 100%, and there are 30% chances of local recurrence. Pathology, the tumor develops following a chronic antigenic stimulation. There is nodular or diffuse infiltrate, which is extending from dermis down to the subcutaneous fat. It consists of neoplastic cells surrounding the reactive lymphoid follicles. The reactive lymphoid follicles are unequal size. They are discrete and with tingible body macrophages and with germinal centers. B cells with a small to medium nuclei and abundant cytoplasm. Mitosis is usually inconspicuous and lymphoplasmatoid infiltrate along with histiocytes and plasma and eosinophils are seen. So the primary marginal zone lymphoma is characterized by diffuse infiltrate by the lymphocytes, diffuse lymphoid or B-cell infiltrate, and all cutaneous B-cell lymphomas are characterized by dissection of collagen. So the collagen is transversed or dissected by the lymphocytes. In addition to the diffuse infiltrate of the B lymphocytes, there are residual germinal centers seen as well within the histological sections. And among the germinal centers, you can appreciate the light zone as well as the tingible body macrophages. So this is a uniform population of monocytoid B cells. In addition to the B cells, the plasma cells are also present at the periphery of the lesion. Then eosinophils are also seen within the section. So the histology is a mixed type, mainly comprising of monomorphic population of B cells, but there are a hint of germinal center formation with tingible body macrophages and plasma cells at the periphery and eosinophilic infiltrates. If we do immunohistochemistry, then it is CD20 positive, CD79 positive, which is also a stain of for the B cells. Then it is CD43 positive, which is the special stain for the marginal zone lymphoma. It is CD5 negative and CD10 and CD23 negative as well. If we do CD20 positivity and if we find that it is CD5 negative and then CD43 is positive, then it is there is no doubt that it is a marginal zone lymphoma. Kappa light chain expression is seen in the tumor, while lambda light chain expression is negative. CD21 stains the follicular areas or germinal centers, which are although present but are rarely seen in the section. Treatment. Radiotherapy is appropriate with excellent long-term prognosis. Surgical excision is done for smaller lesions. Interferon alpha may be effective either systemically or intralesionally. In patients with multifocal disease, there is a requirement of chlorambucil. Cutaneous recurrences are common and can be treated in similar way or similar ways as given above. Then the second primary cutaneous B-cell lymphoma is the primary cutaneous follicular central cell lymphoma. It is an indolent primary cutaneous B-cell lymphoma that is derived from the follicular central cells and consists of mixtures of centrocytes and centroblasts. This tumor was once known as the reticulohistiocytoma of the dorsum or the crusty lymphoma. This term comes in the old literature, but now the term is the primary cutaneous follicular central cell lymphoma. Presents as aggregates of erythematous tumor nodules on the trunk, like this. Other sites are head and neck, more in males, mainly in 6th decade. The estimate 5-year survival of primary cutaneous follicular central cell lymphoma is 94 to 97%. Recurrence is 9 to 22%. There will be a nodal or the nodal or systemic spread is relatively uncommon. So the primary cutaneous follicular central cell lymphoma presents as multiple follicles seen within the dermis with a gran zone. So the tumor presents as follicles, but there are no germinal center, there is no mental zone, and no tangible body macrophages. These were all the features of marginal zone lymphoma. So these features are not present in this primary cutaneous follicular central cell lymphoma. So it is comprising of primarily of primary follicles, follicle-like structures. Among these follicles, there are 2 types of cells, the mature lymphocytes and the centrocytes. And a few mitosis as well. The centrocytes have irregular hyperchromatic nuclei. These are the centrocytes with irregular hyperchromatic nuclei. In addition, there are centroblasts. The centroblasts are cells with oval or vesicular nucleus with 1 to 3 nucleoli. So the nucleoli containing cells are the centroblasts. And the tumor is graded according to the number of centroblasts present within the tumor. Number of centroblasts present in 10 high power field, that is the 40 magnification. If the number of centroblasts is only 1 in 10 high power field, then it is graded from 0 to 5. So it is graded as 1 if the number of centroblasts are 0 to 5 in 10 high power field. It is graded as grade 2 when the number of centroblasts are from 6 to 15 in 10 high power field, that is 40 magnification. And the tumor is graded as grade 3 if more than 15 centroblasts are seen in 10 high power fields. Primary cutaneous follicular central cell lymphoma, like all B-cell lymphomas, are CD20 positive. Then CD21 highlights the follicular nature of the tumor. CD5 is negative, which is negative also in marginal zone lymphomas. But this tumor is CD10 positive. So CD10 is the specific marker for this tumor. And it is also it is BCL6 positive as well. The high grade lesions, the grade 3 lesions, show brisk mitotic activity and are strongly positive with Ki67 or MIB1. Treatment. Superficial radiotherapy is treatment of choice for solitary, recurrent, and multifocal cutaneous disease. With systemic involvement, single agent treatment with chlorambucil or combination chemotherapy may be advised. Solitary lesions may be excised, although subsequent radiotherapy is probably advised to reduce the chances of recurrence. There is a third type of primary cutaneous B-cell lymphoma, which is called as the large B-cell lymphoma leg type. The primary cutaneous diffuse Large B-cell lymphoma is characterized by diffuse proliferation of large B cells consisting of centroblasts and immunoblasts. Clinically presents as bluish red nodule on the leg of elderly women. Other side are the head, neck, and trunk. Since it primarily involves the leg, so this tumor is called as the leg type. Common extra skin site include the gastrointestinal tract. These are the primary bluish red nodules present on leg of an elderly female. This is the characteristic clinical appearance. And also other sites may be involved, characterized by erythematous papules. This is an aggressive tumor with poor prognosis and 5-year survival of around 55%. If occurs in elderly lady on leg, it may be associated with a poor prognosis with 5-year survival of less than 58%. If it is transformed from a marginal zone lymphoma, then it has a further poor prognosis. Histology is characterized by thin epidermis, a Gren zone, and diffuse infiltrate of large B cells in the dermis. And this infiltrate extend deep into the subcutaneous fat as well. The tumor cells have large vesicular nuclei. You can see these large vesicular nuclei. And conspicuous eosinophilic cytoplasm. These are the centroblast-like cells or large cells with eosinophilic nucleoli, which are immunoblasts. So if they are eosinophilic nucleoli, then these are immunoblasts. And if they are basophilic nucleoli, then it is the centroblasts. Frequent mitosis is also seen in this tumor. Diffuse B-cell lymphoma is CD20 positive, CD79 positive, CD19 and CD22 positive as well. But the main, and it is also, BCL2 is also positive. We show the proliferation in 100% of the cases. The main marker is the uniform BCL6 positivity and MUM1 positivity, which is seen in 74% of the cases. Diffuse large B-cell lymphomas have the tendency to invade the endothelium of small blood vessels. And you can see the proliferation or infiltration of lymphocytes within the blood vessels. These lymphocytes have hyperchromatic nuclei and appear to be attached to endothelium in a hobnail fashion. And these vessels are blocked and later on recanalized by these lymphocytes. And if we do CD20 stain, then CD20 is positive within the vascular lumen, showing the intravascular infiltration of these lymphocytes. Treatment. In elderly patient with solitary tumor, radiotherapy is appropriate, but multi-agent chemotherapy is usually required for multifocal disease. The CHOP therapy or CHOP-R is now the standard care for diffuse nodal large B-cell lymphoma with subsequent field radiotherapy. Role of rituximab, which is anti-CD20 antibodies, in cutaneous disease has yet to be determined, but has proved effective in relapsed nodular diffuse large B-cell lymphoma with or without chemotherapy. Then intralesional rituximab has also been tried in solitary lesions, but more research is required to determine its effectiveness. Then the second category of B-cell lymphoma are the secondary B-cell and non-Hodgkin lymphomas. These are the two types of B-cell lymphomas in which skin is involved, but it is involved primarily as secondary involvement after the nodal involvement. And these tumors include the small cell lymphocytic lymphomas and mantle cell lymphomas. Very rarely, mantle cell lymphoma occur as a primary cutaneous tumor that involves the skin as a primary involvement. First, the mantle cell lymphoma. It is a rare cutaneous B-cell lymphoma, which is derived from the mental zone of the germinal centers. Male-female ratio is 4:1 and mainly seen in 6th decade. It is a high-grade lymphoma and responds poorly to treatment. It rarely presents on skin and invariably associated with systemic disease. It involves lymph nodes in 87 to 90% of the cases, bone marrow in 80%, spleen in 47 to 60%, and liver in 13%. It is also associated with B symptoms, which are weight loss, fever, and night sweats. It has high mortality with median overall survival of 3 to 4 years. The poor prognostic indicators of mantle cell lymphoma are the old age, hemoglobin less than 12 gram per deciliter, poor performance status of the patient, and blood involvement. Histologically, the mantle cell lymphomas are characterized by nodal or diffuse proliferation of B-cell lymphocytes. And the lymphocytes are monomorphic with hyperchromatic nuclei. The nuclei may be irregular and mitoses are seen frequently. These are the few mitoses seen within one high power field. The tumor is typically cyclin D1 positive, which is positive in 91% of the tumors. Then the secondary cutaneous B-cell lymphoma is the small lymphocytic lymphoma. This is a tumor of small B cells. It remain restricted to the tissues. Prognosis is generally good as compared to the mantle cell lymphoma. Face, scalp, trunk, and extremities are involved. Lesions are violaceous or erythematous plaques, nodules, or pruritic erythroderma. So erythroderma is possible in only this type of B-cell lymphoma. The chronic lymphocytic lymphoma comprises of diffuse infiltrate of small lymphocytes. Mitosis is sparse. Germinal centers are not seen. The main immunohistochemistry marker is CD23. So these tumors are CD20 positive, CD5 positive, and then CD23 positive. Secondary B-cell lymphomas. Secondary B-cell lymphomas present as large deposits extending through the dermis into the subcutaneous fat. There is a Gren zone and dissection of collagen is seen. Tumor follicles are sometimes evident. Follicles are composed of monotonous tumor cell proliferation and infiltrate the erector pili and appendageal structures. Dissection of collagen is a feature. Then cutaneous plasmacytosis. Cutaneous plasmacytosis is a rare condition that is characterized by a triad of cutaneous lesions, superficial lymphadenopathy, and polyclonal hypergammaglobulinemia. Polyclonal is important. Skin lesions are pruritic, reddish-brown macules, papules, or nodules. Trunk is most commonly involved. There is high ESR and interleukin-6 levels. ANA may be positive. It is CD20 positive. CD38, which is a marker of plasma cell, is positive. And CD79 is positive or negative. So the cutaneous plasmacytosis is characterized by dense superficial and deep perivascular infiltrate of plasma cells, mature plasma cells. Cytological atypia and mitosis are rare in this case, and it has to be differentiated. This cutaneous plasmacytosis has to be differentiated from multiple myeloma because there is no atypia here, and bone marrows are not involved, and there is no clonal proliferation, and Benz-Jones proteins are not seen in the urine, so this is not a multiple myeloma. And it should be excluded from the secondary syphilis, because secondary syphilis is also characterized by plasma cell infiltrate surrounding the blood vessels, but also characterized by endovasculitis or vessel wall narrowing, then connected vessel lumen narrowing and connective tissue diseases. Cutaneous plasmacytoma is the clonal proliferation of plasma cells without evidence of multiple myeloma. So it is the clonal proliferation. It is a malignant tumor of plasma cells, but no associated multiple myeloma, either localized to bone, or which is osseous or extramedullary sites. Variety of sites are involved, and skin is involved in 4% of the cases. Direct cutaneous spread from underlying bone or complicated by plasma cell leukemia. Solitary plasmacytoma has poor prognosis, and patient dies within 6 months of diagnosis. Clinically present as red or purple nodule, maybe single or multiple. Male-female ratio is 4:1, and mainly patients are middle-aged or elderly. So plasmacytoma is characterized again by diffuse infiltrate by plasma cells, but now you can see that the cells are atypical with Russell body formation, mitotic figure, and two Church bodies. Like all plasma cells, these cells are CD38 and CD138 positive, and negative for CD20 and leukocyte common antigen. Their kappa chain expression is seen and lambda chain expression is absent. Treatment is excellent response with excision and radiotherapy. Now, secondary B-cell lymphoma, which is called as the lymphomatoid granulomatosis. It is actually a B-cell proliferative disorder, which is associated with Epstein-Barr virus infection. It is typically characterized by angiocentric, angioinvasive, or angiodestructive, atypical lymphoid infiltrate, and reactive T cells. So the B cells or our secondary B cells are mainly angiocentric, which not only invade the vessels but destroy the vessels. Along with that, reactive T cells are also present. It is associated with immunosuppression, so has been associated with transplantation, HIV, and certain inherited syndromes. It is mainly a pulmonary disease, and in addition to the lungs, skin is involved in 25 to 50% of the cases, brain in 26%, kidney 32%, and less extent liver, spleen, lymph node, and bone marrow. So this chest X-ray shows multiple and bilateral, round, nodular, or sometimes diffuse fluffy infiltrates. CNS involvement is associated with poor prognosis, occur at any age but common in 4 to 6 decades, more in male. There is high mortality and median survival is only 14 months. The cause of death is the lung damage, CNS involvement, and secondary infections. Skin lesions are characterized by widespread erythematous maculopapular lesions. On the trunk, these lesions form annular configuration, which is seen on arms, shoulder, and chest. There may be ulceration, and patient may present with gross nasal destruction. In older literature, the term of lethal midline granuloma was associated or was actually the same condition. That is the lymphomatoid granulomatosis involving the nose. So as I've explained before, this is mainly an angiocentric lymphoma in which the atypical lymphocytes are seen primarily surrounding the blood vessels and involving the deep dermis as well. There is abundant karyorectic debris, but fibrinoid necrosis of vessel wall is not seen. So it is not primarily a vasculitis, but just an infiltration of blood vessels with lymphocytes. You can see these lymphocytes lining the blood vessels. And here the infiltrate is polymorphic, that is, in addition to the lymphocytes, there are histiocytes, plasma cells, and atypical cells. The tumor is less aggressive if infiltrate is more polymorphic. That is, if histiocytes and other cells are present, then it is a polymorphic infiltrate, and such tumors are less aggressive. And if the lymphocyte atypia is and blast cells are less, then it has a poor prognosis, and plus if Epstein-Barr virus positivity is seen. It will be more aggressive if the infiltrate is monomorphic, mainly atypical lymphocytes, and Epstein-Barr virus positivity is very conspicuous. So the reactive lymphocytes are CD3 and CD4 positive, and atypical lymphocytes are CD20 and 79 positive with variable positivity of CD30. Treatment. Although some patients have spontaneous remission, the development of high-grade disease is associated with median survival of 2 years. Short-lived remission with high-dose chemotherapy have been described. There are reports of response to cyclophosphamide and interferon alpha for patients with low-grade disease. I thank you all for a patient listening. I know that it is a difficult topic, and you have to go through this lecture twice to have a better understanding of the subject. And if still you have some questions, then you can inbox me with your queries. Thank you all and have a good day.